Welcome back to the game changer session. This is our pharmacology part. Let us start with this pharmacology part of this game changer session. It is asking about the phase of clinical trials. They will ask you, what is the name of the clinical trial where you will use, or what is the phase of the clinical trial where you will use this, or where you will see this maximum tolerability doses, or where you will measure this maximum tolerable dose. What will be the answer for you? What will be the answer? It will be what? It is the phase 1. So remember, there are different phases of drug testing. If you see about phase 0, it is just the microdosing. It is just the microdosing, usually done before human healthy volunteers. Whereas in a case of phase 1, it will be done in a healthy people. Remember, only is the phase 1, like because we consider phase 1, phase 2, phase 3 and phase 4 as a proper clinical trial. So phase 1 will be what? It will be done in a healthy human individuals. Whereas in a case of phase 2, phase 3 and phase 4, it will be done in patients. So if they given in a healthy individual, which of the following phase you will do? Option A 1, option B 2, option C 3, option C D 4. What you will choose? Yeah, good Dr. Nida Khan, good Dr. Ansh. Okay, it is what? It is the phase 1. The phase 1, it will be for this human healthy volunteers. Okay, it is the healthy human volunteers. And in phase 1, we'll measure this. Yeah, good Dr. Sadaf. And in phase 1, we'll measure the maximum tolerable dose. MTD will measure in a case of phase 1. Whereas in a case of phase 2, what we'll do? We'll do a testing which is known as efficacy. How the drug is efficacious. So we'll do efficacy testing in a case of phase 2. Whereas what we'll do in a case of phase 3? In a case of phase 3, we'll confirm the efficacy which is being tested in the phase 2. In phase 2, we'll give less number of patients. We'll do this in less number of patients. Whereas in the case of phase 3, we'll do from around 500 to 5000 patients. Okay, and we'll confirm this efficacy that yeah, that this drug is working and this drug is miraculous. ठीक है ना? फिर उसके बाद चलते हैं fourth. The stage 4, it is actually what it is, this post marketing surveillance. ठीक है ना? After stage 3, the drug will enter into the market, means the drug will be sold. Once the drug is being sold, then it will be in the market, right? So it will be in the market. So once the drug is in the market, then we need to monitor the side effects and its rare phenomena. Mainly the rare side effects, it will be come through this post marketing surveillance. Fine. So that is the post marketing surveillance, which is especially for this long term outcomes and very rare side effects. And this also done in the patients, and it is very widely ranged because as it is available in the market, many of the patients will start using this drugs. So these are the 4 phases you need to remember. 0 is for microdosing, so just keep it aside. 1, it is for what? It is for this detecting of this maximum tolerable dose in human healthy volunteers. Fine. And in phase 2, it is the efficacy testing done in a small number of patients. Phase 3, it is done in a large number of patients and it is to confirm the efficacy. And phase 4, it is what? It is this measuring this rare side effect or this post-marketing surveillance. Fine. And it is also done in patients. Remember these 4 points about this healthy or this randomized control trial phases. Fine. Yeah, maximum usually it will fail between 2 and 3. Just remember. And about this efficacy and potency graph, they will give you this graph and they will ask you which of the following drug is having the highest potency. Can anyone tell me which of the following drug is having this highest potency of this mentioned ABCD? Which has this highest potency in the mentioned curves? Yeah, good Dr. Ansh, good Dr. Naresh, good Dr. Nida. It is what? It is the drug A. Means remember the potency, P for potency and P for pass. Means the nearby one. The nearby one will be having this maximum potency. So if you see the drug A, it is starting here itself. So it is the highly potent drug. Whereas if you see this drug D, it is what? It is this starting late. So it is very less potent. Whereas if you see about the efficacy, it's about the height of the cow. Okay. How height is the cow, that much efficacy it is. Fine. See, if you see this drug D, it is having this low efficacy. Whereas drug A, if you see, it is having the maximum height. So the drug A, it is the maximum efficacious in nature. Okay. Right. So in this graph, if you see, most of them, they are equi-efficacious. Means their efficacy is normal or is equal. Okay. It is equal in nature. Yeah, good Dr. Ansh. Fine. So these are the things you need to see on this efficacy and potency. So remember potency matlab pass. The drug which is acting at very low dose, it is more potent, okay, and the drug which is having this maximum effect, so it is known as what? High efficiency. It is known as high efficiency, or mainly the height, okay. Next, we'll move to some more formulas, okay. They will ask you about this to calculate this drug safety index, or they will ask you the formula. So remember, the therapeutic index is what? It is this LD50 by ED50, okay. It is the LD50 by the ED50, okay. Next, about this volume of distribution, like once you give a drug, how it will distribute into the body. So the volume of distribution, it is what? It is this amount of drug or the given dose divided by how much amount is reached into the plasma. So our concentration in the plasma, how much it is being distributed. So the given dose divided by concentration of plasma, it is the volume of distribution. Next one, it is the maintaining dose. Like once you give a dose, you will give two type of doses. One, the loading dose to reach a proper half-life, okay, or the max to reach a proper peak effect, and after which you will maintain the dose. So first you need to know about this loading dose. You will think of its clearance and volume of distribution. So for this loading dose, you will think of volume of distribution and clearance, whereas for this maintenance dose, you will just see the plasma concentration and clearance. So both of these will check into clearance, whereas loading dose, how it is widely spreaded, so that how much it can withstand and it can act, that is the loading dose. Whereas maintenance dose is that how much concentration we need to maintain the effect of the drug, that is known as maintenance dose, okay. I hope I'm clear in this formula, and just see this formula because recently the trend is started changing and they started asking about this formulas. So make sure you are reading this formula before going to your examination. And about this part, this enzyme inducers and enzyme incubators, why they are important? Because if you give one drug, and the other drug which you are giving, it may incubate this metabolism of this drug, or it may induce this metabolism of this drug. For example, if it incubate its mechanism, what will happen is that this drug level in the blood, it will keep on rising because the drug will be there, will keep on taking those drugs, so the concentration of the drug in the blood will be increased. So these are this enzyme incubators. Whereas enzyme inducers, what it will do is, this will cause what? This will induce the enzymes. So inducing the enzyme will causing this rapid metabolism of the enzymes. If rapid metabolism occurs, then there will be no drug will be left over for a longer action. So remember, it is these drugs which are this inducer drugs, they will decrease the level of other drugs because of further things. Preeti, yeah, mostly you just remember about this formulas. They won't dive in depth and ask you about the calculations. Mostly the calculations are being asked from the PSM perspective. This formulas you just remember. You don't need to remember about the calculations part. Fine. Next, as what? If you see this enzyme inducers, what they will do? They will decrease the level of other drugs, because what it will do? It will rapidly increase the metabolism. Fine. This include, you can remember as a GPRS cell phone. Okay. Remember, first one, it is the alcoholism, graciofulvin, phenobarbital, rifampicin, smoking, carbamazepine, and phenytoin. So alcoholism, graciofulvin, phenobarbital, rifampicin, smoking, carbamazepine, and phenytoin. All of the drugs, they act as an enzyme inducers. So if you are giving some other drugs with it, you should increase the dose. So that the drug will stay in plasma for a longer time. Whereas in the case of enzyme incubators, what they will do? They will increase the level of these drugs, means they will incubate its metabolism so that the drug won't be metabolized. It will be staying in the blood for a longer duration of time. Okay, these drugs include valproate, ketoconazole, cimetidine, erythromycin, isoniazid, protease incubators in HIV, and omeprazole. So remember, the anti-TB drug which is inducer is rifampicin, whereas anti-TB drug which is incubator, it is what? It is the isoniazid. Can anyone tell me what is the name of the vitamin? Does this isoniazid will cause deficiency of? Yesterday we studied in biochemistry. Yeah. What is the name of this vitamin deficiency will be caused by this isoniazid? It will be caused the vitamin B6. So it is what? It is the pyridoxine deficiency. It is the pyridoxine deficiency which is at the vitamin B6. So remember, it is I6. Okay, isoniazid causes deficiency of vitamin B6. Okay, then we'll move on to these two drugs. These are this brother and sister, like physostigmine and pyridostigmine. Look similar. maybe having some confusion. But remember, this physostigmine, it is what it is, the tertiary amines. This tertiary amine means they're small. Okay, remember it is a small tertiary. Okay, so they can penetrate into the CSF. Whereas this quaternary amines like pyridostigmine and neostigmine, they cannot cross the blood-brain barrier, and so they cannot enter into the CNS. So in case of any CNS conditions, we can use this drug. For example, in a case of Alzheimer's disease where there is a decreased level of acetylcholine, in a case of such conditions, we need to increase the level of acetylcholine. There are different methods of increasing acetylcholine. Whether either we can directly increase, they are known as direct acetylcholine increasing drugs. Whereas there are few drugs, what will do, they will act indirectly. What they will do is that there is an enzyme which causes metabolization or which causes breakdown of this acetylcholine. They are known as acetylcholinestrases. So this drug will go and act on those drugs, and it will cause less degradation of the acetylcholine, by which the acetylcholine is meant to stay for a longer duration. So this is the role. So if you see this physostigmine, it is used in a case of Alzheimer's disease. It is used in a case of Alzheimer's disease. Yeah, guys. Yeah, Alzheimer's disease will use some more drugs. Yeah, the one of them, this categories will come under this donepezil. Okay, remember it is the donepezil which is used in the Alzheimer's disease. And next, physostigmine. Physostigmine, it is used in a case of atropine poisoning. So physostigmine, it is used in a case of atropine poisoning. So if you see in the case of atropine poisoning, it is the blockage of this parasympathetic system. Whereas to bring it back, we'll use this parasympathomimetic drugs like physostigmine, and it will increase it. So on atropine toxicity and datura poisoning and atropa belladonna poisoning, all of them will look almost similar. Okay, they'll be having a few typical features that I will explain you in further on. So just remember about the physostigmine, it is the drug of choice for atropine toxicity, whereas for Alzheimer's disease will give donepezil. Alzheimer's disease will give donepezil. Next, about this quaternary amines, I told these are very large components and they cannot penetrate into the CNS. अगर ये CNS में penetrate नहीं करता है तो क्या होगा? It will stay in the outside, or it will stay in the blood or in the peripheries. So we can use in the case of conditions where we need them in peripheries. For example, in the case of myasthenia gravis, हमें पता है in the case of myasthenia gravis, the antibodies, they are against this acetylcholine receptors. So in such cases, what we'll do, we'll increase the production or increase the release of acetylcholine in such cases. So that is what this pyridostigmine does. Okay, and this pyridostigmine is used in a case of myasthenia gravis and cobra bite. Like especially the neostigmines will be used in a case of cobra bite, and in a case of toxicity from this skeletal muscle relaxants, because muscle relaxants, they are peripheral acting, right? There we can use this neostigmine or pyridostigmine. And there is one more class of this drug which is known as endothorium. This endothorium, it is a very short acting drug, and this endothorium, it is used for diagnosis of this myasthenia gravis. So endothorium, it is used for diagnosis of which disease? Myasthenia gravis, and the name of the test, it is known as Tensilon test. So this Tensilon test, it is used for the diagnosis of this myasthenia gravis. बस इतना याद रखो. So myasthenia gravis will use neostigmine or pyridostigmine. Okay, and physostigmine will use in a case of atropine poisoning, and donepezil will use in a case of Alzheimer's disease, whereas pyridostigmine will use in a case of myasthenia gravis, and endothorium, it is used in a case of Tensilon test. बस इतना याद रखो, हो जाएगा. Then about this OPC poisoning. Next one about this OPC poisoning and carbonate poisoning. So we know this OPC poisons, what it will does, it binds to the receptors and it causes overstimulation of the parasympathetic system. So once it causes this overstimulation of this parasympathetic system, it will be showing these features of what? There will be showing the features of increase in secretions, like there will be increase in lacrimation, increase in salivation, increase in vomiting, and increase in urination. So all of the secretions will be more. Okay, their secretions will be more, whereas the pupil will become constricted. We'll call them as pinpoint pupil. We'll see this pinpoint pupil, and in lungs there will be bronchoconstriction. Bronchoconstriction, and there will be in heart, there will be bradycardia. So there will be bradycardia, bronchoconstriction, pinpoint pupil, and there also will be all secretions as I told, and this diarrhea also will be there. And if they act on this muscular receptors, it will result into this muscular weakness. Yeah, we'll call them as dumbbells simply. Yeah, if you know these dumbbells, just keep them as. Okay, so these are the symptoms which we'll see in a case of OPC poisoning. But see, there are two poisonings. OPC, there is two reasons. One is this acetylcholine levels have been increased, and why it is increased? Because this enzyme which is breaking down this acetylcholine is not active. So now we need to reactivate the enzyme. So we'll give two drugs. One drug to decrease the symptoms and mask the signs, and second drug to reactivate this drug. So the first drug will give it is what it is the atropine, and the second drug will give it was what it is the pralidoxin. So atropine, it blocks the receptor, but still there is an increase in ACH levels will be there, but it will not reverse the effect of the neuron junction and acetylcholinesterase binding. So we'll at the moment will give what? Will give the pralidoxin, or also known as PAM. Whereas in a case of carbamate poisoning, only atropine is enough. Whereas oximes like pralidoxins will be contraindicated in a case of carbamate poisoning. Okay? Yeah, good, Dr. Naresh. Yeah, that is atropine plus oximes in a case of OPC, whereas only atropine in a case of carbamate poisoning. That's it. Next, about the atropine uses. Fine. We saw this atropine, it is what it is. It will opposites the action of this parasympathetic system. Okay, so if you give atropine in a bradycardia patients, it will increase the heart rate. So usually atropine, it is used in the clinical settings to increase the heart rate, and we saw this OPC, it is a parasympathomimetic. So parasympathomimetics causes constriction of the pupil, whereas this atropine will cause what? It causes powerful dilatation of the pupil. Okay, powerful dilatation of the pupil. Mostly about this atropine and toxicity, they will be having this typical history. This fruit, which I will show in the forensic part, which is known as this roadside poison, which is this datura, and if it is being thrown into you, you'll be having this datura poisoning, which will be having this active component of hyoscine or atropine, and in such cases, the datura will be having all these. D for it will be having this dry mouth and delirium, and there will be features of hyperthermia. You will be dry, so you will be hyperthermia, you'll be having this agitation, and there will be tachycardia. Dry mouth, delirium, hyperthermia, agitation, tachycardia, and there will be the features of urinary retention, and there will be accommodation will be lost. That's why we use this atropine in a case of dilatation of the pupil, and mostly especially in a case of children's, we need very powerful dilatation, and that is being done by this atropines. Okay, and for treat this atropine poisoning, we already studied the drug we use. It is what? It is the physostigmine. Good, Dr. Anjali. We'll use what? We'll use physostigmine. Okay, then we'll move on to the few drugs of anti-Parkinson and anti-Alzheimer's drugs. We saw already one anti-Alzheimer drugs, which is this donepezil, and we know donepezil, it is the drug of choice for Alzheimer's disease. Whereas for Parkinson, there are different drugs. For example, if it is a drug induced Parkinsonism, we'll use these drugs like benzhexol, benztropine, and bipredin. Whereas in other cases, we'll combine with the levodopa. Whereas in a case of drug induced Parkinsonism, we'll use benztropine, benzhexol, and bipredin. Okay, whereas in rest cases we'll use levodopa and with other combinations. Okay, because we know Parkinsonism, it is due to the decreased level of dopamine. फिर उसके बाद आते हैं Alzheimer's disease. We know Alzheimer's disease, it is due to the deficiency of acetylcholine. तो हम क्या करेंगे? If we inhibit this enzyme, then we'll increase the level of acetylcholine in the blood. और हमें पता है कि quaternary amines they won't cross, so we need to use tertiary amines. So we'll use this drug which is known as what? Donepezil, and other drugs like rivastigmine, galantamine, and we recently introduced one antibody which is this adacanumab. Remember, it is adacanumab. So it is used for Alzheimer's disease, and this drug, as I told you, there is one more drug which is used in case of Alzheimer's. It is what it is, memantine, which is an NMDA receptor blocker. It is used in a case of Alzheimer's disease. Yeah, it is. Yeah, mostly I will write like, but mostly the names will be, it is already written here. So this Parkinsonism, just remember, in usual scenario will use levodopa. Okay. So mostly the drug names it is written, and few drugs I will be writing. So don't worry, I will write it up. Okay, don't have any things. Okay, if any, please reach me out. I will help you out. Okay. Right. Next, about this receptor comparison. If you see about this adrenaline will act on most of the receptors like alpha 1, beta 1, and beta 2. Okay, so their net effect is what? It is the increase in heart rate. Whereas noradrenaline, if you see, it will increases the mean BP, whereas their net effect on heart rate will be low. So that's why if there is any decrease in BP, if there is any prolonged decrease in BP, then we'll use noradrenaline. Okay, and we know if we need to increase this BP, along with that we need to increase the heart rate. In a case of like during CPR, then we'll use adrenaline. Okay, isoprenaline will be having no or less effect on this mean BP, whereas it will increase this heart rate to a maximum extent because of this beta 1 stimulation. बस like just keep this thing in mind. फिर उसके बाद आते हैं adrenaline. Sorry. In adrenaline we know it is used in different types of shocks. One is the cardiac shock. In cardiac shock, mostly we'll secure the IV line and we'll give them in IV with a concentration of 1:10,000. Whereas in a case of anaphylactic shock, for example, there is a swarm of bees which has bitten, leading to this anaphylactic shock. So in such conditions, we'll give either subcutaneous or IM with a ratio of 1:1000. In a ratio of 1:1000, and this is how we usually do. Whereas in some special situations, we can give this adrenaline even endotracheal route as well. Okay, so there is this cardiac arrest will give IM, whereas anaphylactic shock will give means in cardiac will give IV, in anaphylactic shock will give IM. Okay, and in a case of brittle asthma, how will you give? Yeah, guys. In a case of brittle asthma, you will give in a subcutaneously. So we'll call them as EpiPen. Okay, EpiPen. So in brittle asthma, we'll give subcutaneous. And about this noradrenaline, as I told you, it will increase the BP or it will maintain the BP, okay, without increasing the heart rate. So noradrenaline is used as a drug of choice for septic shock. And dopamine, there will be a different receptor involvement. See, there will be involvement of this D1 receptor, beta 1 receptor and alpha 1 receptor. And because of this D1 receptor, then it can cause this diuresis. So because it can cause diuresis, so it is one of the drug of choice for cardiogenic shock and which is presenting with oliguria. So cardiogenic shock plus oliguria, the drug of choice is dopamine. Whereas noradrenaline is used for septic shock, whereas cardiogenic shock, it is adrenaline. And anaphylactic shock also adrenaline, just remember. Yeah, good. Next about this dobutamine, it is used in a case of congestive heart failure. Dobutamine, which is used as to increase the inotropic action of the heart. So see, so to increase this inotropic action or to increase this contraction of this heart, what we'll use this dobutamine because of this beta 1 stimulation, Okay, फिर उसके बाद we'll see this reaction which is known as vasomotor reversal of Dale. So if you see, normally usually this is the normal BP. So if there is this adrenaline, like if there is any noradrenaline which is being secreted from this pheochromocytomas, then what will happen is this will go and stimulate and will cause hypertension. If you just give alpha blockers, it will drop down the BP to this level. Whereas we know if we give this alpha blocker along with this beta blocker in a case of noradrenaline secreting pheochromocytoma, means normally the BP is this, and in pheochromocytoma there will be increased in BP. And when you give this alpha blocker, the BP will drop. The BP will drop initially. But if you give more beta blocker as well, then what will happen is that it will cause more hypotension. Remember, this is known as vasomotor reversal of Dale. Okay, just remember, it is most commonly seen in a case of pheochromocytoma. Yeah, there is this unopposed fall of BP. That's good, Dr. Shanaska. If you see about this beta 2 agonist, there will be like what? They are this bronchodilators usually used in a case of asthma. And we know there are this SABA, LABA, means they are this short acting and the long acting. And SABA, it is a short acting which acts for less than 4 hours. They includes this salbutamol, okay, salbutamol and terbutaline. And LABA, it includes salmeterol and formoterol. So meterol will be used in a case of, they are classified as the case of long acting beta agonist, whereas SABA, it is used in asthma. It is a what? It is a very short acting. A good, Dr. Anjali and Shanvas Khan. A good, well tried. Fine. Next, the side effects of this beta 2 agonist, which includes tremor, tachycardia, hypokalemia, and these are this main one. Like for example, if there is a chronic usage of this beta 2, there will be stimulation of this beta 2 receptors leading to tremors, and there will be some extent of this beta 1 stimulation leading to tachycardia, and also it causes this one of the significant side effect, which is this hypokalemia. That's why we can use in the case of hyperkalemia. In the case of hyperkalemia, what we'll do, we'll give salbutamol nebulization. Salbutamol nebulization. We know in the case of hyperkalemia, we can use one more drug, which is this insulin. Okay, we can give insulin, which causes shifting of this potassium level from the blood to the cell. The same wise, this salbutamol, what it will does, this salbutamol, it will put the potassium into the cells. So that is why it causes hypokalemia. So it is tremors, tachycardia, like palpitations, and hypokalemia. And next, there is this beta 2 agonists, which are being used as tocolytic agents, means during a preterm labor. Imagine the labor should start after more than 36 weeks. But if the labor or this labor pains start before that, then the baby will not mature yet. Means especially the lungs are not matured yet. So we need some time to make this lung to be matured with steroids. So in such cases, we'll give this tocolytic drugs. These tocolytic drugs, which include ritodrine and isosporin. Ritodrine and isosporin. Just remember these two drugs. Next, about this blood drugs. If we see, you need to remember these two drugs, heparin and warfarin. We know heparin we cannot give in oral route. Mostly we'll give in IV, or like mostly we'll give in a race of subcutaneous route and sometimes in IV route. Okay, so this heparin one, it acts by activation of this antithrombin 3. Okay, it's an anticoagulant. Whereas warfarin, it inhibits this gamma carboxylation of 2, 7, 9, 10. It inhibits this gamma carboxylation of 2, 7, 19. So it will inhibit this vitamin K. Next, for this heparin, what it will do is that this heparin we need to test. For example, you have given a patient for heparin, but you need to monitor them, right? Like whether you are giving this adequate amount or you are given more than that, or the T-half you are giving or the maintenance dose you are giving is more or what. So in such cases, you need to know about this monitoring. You need to do tests. So remember, WEPT. WEPT. Warfarin, it acts on this extrinsic pathway which is mainly involved, and it will be measured using the PT. That is, the PT will measure using for warfarin, whereas this PTT or APTT will use for this heparin. APTT will use for this heparin, fine, and it is for this short term use because we are using in subcutaneous route, right? It is used for short term use, whereas this can be used for a long term. That's why in the case of any metallic valve patients, then we'll prefer warfarin than heparin, fine. Then about, we have this antidote for this, it is the protamine sulfate, and the antidote for the warfarin, it is what it is vitamin K. Okay, but the main game changing effect is this. This heparin can causes placenta and can cause heparin induced thrombocytopenia and bleeding. And one more thing is that this heparin, it won't cause any defects. Okay, it won't cause any defects during this pregnancy. So that's why in the case of anticoagulants in pregnancy, for first few weeks we'll give heparin. Okay, then after that we'll shift to warfarin, because for first trimester this warfarin will cause incubation in this organogenesis. Then around the delivery, around 36 weeks, we'll again shift to heparin. Okay, again shift to heparin, fine. Then about this low molecular weight heparin. This low molecular weight heparin, that is the modified form of the heparin, which is incubits this factor 10A more than the factor 2A. Fine. And fondaxpiranas, it will just incubate the 10A, means so that how much less it is incubating, that much less is the side effect. Fine. Yeah. INR, var. Like, so remember, we can use one more thing which is known as what? Yeah. For this money, there is a war which is going on. So remember, this PT, it is one more centralized form which is known as what? International normalized ratio. So international normalized ratio, which we'll commonly use to compare between these two labs, whether the lab volumes were adequate or not. So warfarin will use PT and INR, fine. And as I told you, warfarin we won't prefer during the time of organogenesis, so it will be contraindicated in this first few trimesters of pregnancy. Okay, so because it is teratogenic, it will cause this one more syndrome as a side effect, which is known as purple toe syndrome. will cause purple toe syndrome. And means in a case of acute bleeding, for example, in a case of acute bleeding, we won't prefer warfarin, because in a case of acute bleeding, what will happen is that warfarin will take some time to go and incubate this gamma carboxylation. So in a case of acute episodes, we use subcutaneous heparins or low molecular weight heparins. Okay, in long-term management, we'll use warfarin. Okay, I guess you got you guys. Then about the new generation drugs. These new generation drugs, they are known as that what direct acting oral anticoagulants. There are few, they are oral, but there are few drugs which are oral in nature, whereas few drugs they are taken IV. For example, in the case of direct thrombin inhibitors like dabigatran, it can be taken orally. So remember, it is the dabigatran, it is the direct thrombin inhibitors. Okay, and some of them they are used in a case of heparin induced thrombocytopenia, which include lepirudin and argatroban. Okay, lepirudin and argatroban. They will ask you which of the following is the only oral direct thrombin inhibitors. The answer is what? It is the dabigatran. It is the dabigatran. It is the dabigatran. Okay, and yeah, the Bakipio. Okay, fine. Then, if you see this antidote, sometimes there can be this scenario there this anticoagulant action has been overwhelmed. In such cases, we'll use this antidote, which is this idarizumab. So remember, it is the idarizumab. So dabigatran, idarizumab. Dabigatran is the drug which we take orally, whereas it is will be incubated by this idarizumab. Fine. And there is few more drugs. They are known as factor 10A inhibitors. Okay, factor 10 inhibitors. So whatever the 10 inhibitors, their name will be having this XA. So it is rivaroxaban and apixaban. They are this factor 10A inhibitors, factor 10A inhibitors. And antidote of this factor 10 inhibitors, they include this andexanate alpha. Here this antidote also will be having this XA. So andexanate alpha, it is the antidote of this factor 10A inhibitors. Fine. And in the case of atrial fibrillation, we prefer less using of this newly added anticoagulants, whereas mostly we'll use what? We'll use this warfarin. We'll use this warfarin for preventing the formation of clots. Fine. And if there is a clot formation, like in the case of MI, previously we used to do a thing which is known as clot lysis. For that, we'll use this fibrinolytic drugs. Previously, we used to use these drugs like streptokinase, but now it is being replaced by this drug which is known as retiplase and alteplase. These are this tissue plasminogen. These are the tissue plasminogen activators, and this tissue plasminogen activators, they will activate the plasminogen and they will lyse the clot. Okay, this includes this retiplase and alteplase. If you see about this anti-hypersensitive drugs, mostly they will ask in which condition or in which condition which drug you will use, or in this clinical scenario of a patient who is presenting with features of hypertensive emergency. Okay, hypertensive emergency means when you will describe it as hypertensive emergency. Hypertensive emergency means when there is an end organ injury is present. It is known as what? It is known as hypertensive emergency. And in the case of hypertensive emergency, what we'll use? We'll use this nicardipine. We'll use nicardipine. We'll use this nicardipine. Whereas in the case of subarachnoid hemorrhages, which is due to this hypertension part, we'll use nimodipine. We'll use nimodipine. So remember, hypertensive emergency, we'll use nicardipine, whereas subarachnoid hemorrhages, in the case of hypertension, we'll be using this nimodipine. फिर उसके बाद आते हैं hypertension with BPH. You know, benign prostatic hyperplasia, उसमें हम क्या देंगे? हम देंगे terazosin. Okay, we'll give this terazosin. Okay, they are what? They are this alpha 1 blockers. We'll give terazosin. फिर उसके बाद hypertension in pregnancy. If just this hypertension in pregnancy, we'll use labetalol. कौन सा labetalol? We use oral labetalol. Okay, more than methyl dopa, because क्योंकि हमें पता है methyl dopa will cause a condition which is known as autoimmune hemolytic anemia. So we'll use what? We'll use labetalol. फिर उसके बाद आते हैं हाइपरटेंसिव इमरजेंसी इन प्रेगनेंसी में इमरजेंसी तक क्या यूज करेंगे? लाइक इन केस ऑफ इमरजेंसी इन प्रेगनेंसी विल यूज द सेम labetalol, but we'll use this labetalol in IV form. So it is IV labetalol will use. And if there is nothing, all of these drugs are 2 to 3 drugs combinations you tried, even on diuretics also you tried, but it is not residing. It is known as resistant hypertension. So in the case of resistant hypertension, you use spironolactone. Yeah, we use what? We use spironolactone. Good, well said. Then if there is a patient who is presenting with this hypertension, CKD and diabetes mellitus, if there is any hypertension along with this kidney involvement and diabetes mellitus, then the patients will give them AC inhibitors and ARB. Okay, angiotensin converting enzyme inhibitors and angiotensin receptor blockers. These are the two drugs we'll use in a case of diabetes along with this kidney damage or if there is any nephropathy. Okay. Next about this diuretics. I don't know why they love asking about this diuretics. Okay, and they love asking about this part of nephrons. If you see, initially this is the glomerulus part. Next one it is the PCT. Around the PCT will be this release of bicarbonate, and we'll use this enzyme which is known as carbonic anhydrase, which helps in the breakdown of this sodium bicarbonate. So this inhibitors mostly they will act on this PCT. And next on the loop we have this sodium potassium 2 chloride pump, and the sodium potassium 2 chloride pump it will be used in the loop of Henle. And if we block this pump, it will be what? It will be the loop diuretics. Okay, loop diuretics. Yeah, good. Dr. Sai Krishna, Dr. Muhammad Sky. Yeah. Or which of the following diuretics will act here? So it is commonly repeated. So don't forget to study this image along with these concepts and along with the drugs and their side effects. Just see these things because it will give you more than 1 mark. Okay, fine. So loop diuretics, it will block at the level of sodium potassium 2 chloride pump. Fine. And next one it is the thiazide diuretics, and thiazide diuretics will be acting on the DCT, distal converter tubules. And in a case of potassium sparing diuretics and aldosterone receptor blockers and ENaC inhibitors, all of them they will be acting at the level of collecting duct. And there is one more drug which is known as what? Osmotic diuretics. This osmotic diuretics mainly they act on this PCT and loop of Henle. It will be act on this PCT and loop of Henle. Yeah guys, correct. Good. Okay, so if you see first image, it is carbonic anhydrase inhibitors which is being act around this PCT, and we know this carbonic anhydrase inhibitors like acetozolamide, and we know this acetozolamide, it is the drug of choice for which sickness? Motion sickness? No, it is the drug of choice for this mountain sickness. It is the drug of choice for this mountain sickness, and it can be used in a case of glaucoma. Yeah, good, Dr. Shanavas Khan. Yeah, good, Dr. Puneet. Yeah, fine. Next about this osmotic diuretics. In case of this osmotic diuretics, what they will do, they will catch up this water. They will pull out this water. The example of this osmotic diuretics, it is what? It is the mannitol. And mannitol, it is used in a case of cerebral edema and acute congestive glaucoma. Means when there is this condition which is known as acute congestive glaucoma or angle closure glaucoma, in such condition there will be rapid increase in the pressure. So in such conditions, to decrease the pressure, we'll use this mannitol. Okay, फिर उसके बाद आगे चलते loop of Henle. This loop of Henle will use this diuretics which blocks this sodium potassium 2 chloride pump, and we know this loop diuretics, they are known as high ceiling diuretics because they cause this maximum water loss. That's why we use them in a case of congestive heart failure to relieve this pulmonary edema. तो pulmonary edema को relieve करने के लिए हम क्या यूज करेंगे? loop diuretics यूज कर लेंगे. और ये भी याद रखना कि loop loses calcium, so we'll avoid them in this calcium stones formations. Yeah, good. The example of this, it is the furosemide. Good, Dr. Shanavas, Anjali and Ayushi. Good, well said. Fine. Next, if you see the DCT, this distal converter tubule, there will be the thiazide diuretics will work. Okay, they will block this sodium chloride importer, and thiazide diuretics, it is one of the important diuretics. Why? If they ask you in the case of initial management of hypertension, what is the drug you will give? It is the thiazides, and there are these thiazides. You can read by this name which is known as chlorothiazide. There will be written thiazide only, but there are two drugs. They are not written thiazide in it, but they are actually thiazides. So remember, it is indapamide and metolazone. Remember this metolazone, it is effective even in renal failure. Okay? Effective even in renal failure. So they will ask you, which of the following diuretics you will prefer to use in a case of renal failure? उसमें हमें बोला कि metolazone, because in the case of chronic renal diseases we avoid using the diuretics, whereas in the case of thiazide diuretics they ask you need to tell metolazone where can be used in a case of renal diseases. Okay, and as I told you, this is used in a case of hypertension, and this saves the calcium. So it won't cause urinary excretion of calcium, so we can use in a case of calcium stones, and we can use them in a case of diabetes insipidus. And as they saves calcium, they can be used in a case of osteoporosis. Osteoporosis में भी हम use कर सकते हैं इसको thiazide को. Okay, yeah, one of this absolute contraindication is the gout and hyperuricemia. Because the thiazide what it will do, it will increase the uric acid level and it will cause decrease in the value of this all other electrolytes. So since it causes increase in the uric acid levels, we'll avoid using them in a case of gout. Okay? Then about this collecting duct, there will be this potassium sparing diuretics. If you see all of them, this LH like loop diuretics and thiazide diuretics, both of them, they will be losing the potassium. So we need a drug if the patient is already in hypokalemia, but if you lose more potassium, the patient will be more hypokalemic. So in such scenarios, you need to use this potassium sparing diuretics like aldosterones, okay, and like spironolactone and epinephrine, okay. And there will be this some more drugs which are known as epithelial sodium channel blockers. And this epithelial sodium channel blockers, which include triamterene and amloride. Remember about this amloride. This amloride, it is used for the drug of choice for lithium-induced diabetes insipidus. Usually, thiazides are the drug of choice for the diabetes insipidus, whereas amloride, it is used for the management of this lithium-induced diabetes insipidus. Remember, and we know this spironolactone. This spironolactone, which is actually which is this aldosterone receptor antagonist, they'll be having this side effect of gynecomastia. We studied in the morning, there is a syndrome which will be having this gynecomastia as a clinical feature. What is the name of the syndrome, guys? What is the name of the syndrome which is associated with the gynecomastia? It is what? It is the Klinefelter syndrome. It is the good, guys. It is the Klinefelter syndrome. Good, Diana. You have this strong memory power. Like it is the Klinefelter syndrome. Very well. Okay, see, so in a case of Klinefelter syndrome, you will be able to see what? You will be able to see this feature of gynecomastia. Fine. And to prevent this in males, will give eplerenone. And this is the drug of choice which we use in a case of cirrhosis-induced congestive heart failure and Cone syndrome. Cirrhosis and Cone syndrome will use eplerenone. Okay. Then about this ACE, ARB inhibitors. We know this ACE and ARB will use in a case of hypertension along with diabetes mellitus and along with the renal dysfunction. Okay, along with this renal dysfunction. Next, this AC inhibitors. Remember, this AC inhibitors will be ending with this names as prils. Captopril, linsopril, and enalapril. We know this captopril. It is what? It is the capto and linso. They are the prodrugs. And as I told, they are the drug of choice for hypertension in case of diabetes mellitus and in a case of chronic kidney disease. Okay, and this will be having these few side effects. There are few side effects which include this. AC inhibitors will be having this maximum side effects, which include this angioedema, cough, which is a dry cough, which is most common one, associated with this angioedema, and along with this taste alteration, which is known as dysgeusia, and this captopril will be having a specific feature or specific or maximum chances of postural hypotension. And this AC inhibitors and ARB inhibitors, they are contraindicated. Especially the AC inhibitors, they are contracted in the case of bilateral renal artery stenosis. So in the case of bilateral renal artery stenosis, AC inhibitors are contraindicated. And remember, this AC inhibitors and ARB inhibitors, both of them, they cause hyperkalemia. Whereas as I told you, salbutamol causes hypokalemia. Then ARBs, they will be having this name as statins. Especially this telmisartan, which is being widely used now because it will be having a function of PPR gamma agonist, and it can even reverse this insulin resistance. That's why in a case of ARB, which we want to use in a case of diabetes patients, we are preferring telmisartan. Fine. Yeah, good Dr. Mohammed and good Dr. Anjali. Good, well said. Good Dr. Puneet and Shavaska. Right. Then about this management of the congestive heart failure. In the case of congestive heart failure, we'll tell them it is a congestive heart failure if the ejection fraction is less than 60%. And there will be two types. One is decompensated, means initial phases are also known as acute congestive heart failure. It is known as decompensated congestive heart failure, where the ejection fraction will be less than 40%. Okay. Whereas in a case of compensated or chronic congestive heart failure, the ejection fraction will be less than 60, but it will be more than 40%. Okay, bas itna yaad rakhna. And here, in the case of congestive heart failure, what are the drugs we'll use? In the case of acute congestive heart failure, it occurred acutely. So it will, what will do? The heart is unable to pump. So it will reflex back its blood. Where it will reflex back? It will reflex back into its lungs. अगर ये lungs में reflex कर रहा, then lungs में ज़्यादा पानी भरेगा, and there will be more water into the lungs. अगर if there is more water into the lungs, हमें क्या करना होगा? We need to remove the water by using the furosemide. So we'll use furosemide to decrease the fluid. Okay, then we need to help the heart to pump more. So we'll increase this inotropes. For example, the inotropes include this dobutamine. We told, right, dobutamine it is an inotrope which causes increased contraction, fine. And we can use one more drug which is an ionodilators, which cause constriction of the heart as well as it will dilate the vessels and decrease the pressure. So this is the management in a case of CHF, which is in acute stage or decompensated stage, fine. Whereas in a case of chronic congestive heart failure, there our approach is very different. Here means the heart is exposed to very long, so it will be adapted to it. In such scenarios, what we need to do is we need to decrease the blood volume or decrease the blood pressure. So in such cases, to decrease this venous return, what we'll do, or to decrease this arterial pool, what we'll do, we'll use this dilators like nitrates, hydralazine, and AC and ARBs. Okay, and AC ARBs, especially this nitrates and hydralazines, they will cause dilatations of the vessels and it will decrease the work. And to decrease the fluid, as usual, we'll use what? We'll use the diuretics and decrease the left ventricular hypertrophy. Because of this long-term pushing, this can lead to this left ventricular hypertrophy. So to prevent this remodeling of this heart, we'll use few drugs like beta blockers, carvedilol, metoprolol, and bisoprolol. Okay, it is what it is, the carvedilol, metoprolol, and bisoprolol. Carvedilol, metoprolol, and bisoprolol. Just remember all these drugs, right? And there are a few more drugs which decreases the mortality, which include sacubitril. They are this A, B drugs like AC inhibitors, ARBs, beta blockers, and ivabradine. Ivabradine, it will decreases this contraction points, right? And the only one diuretics which we use here, it is the spironolactone. That is the spironolactone. And so as we see here, this beta blockers, it will be used in a case of chronic congestive heart failure, whereas it is contraindicated in a case of acute congestive heart failure. बस इतना याद रखना. In acute हमें क्या करना है? हमें blood का volume को कम करना, तो we'll use diuretics. और एडिमा को भी कम करना, तो देन विल यूज डायरेटिक्स. उसके साथ साथ हमें हार्ट का पंप करने का मतलब एनर्जी को बढ़ाना, तो विल इंक्रीज द आइनोट्रोपिक एक्शन बाय गिविंग डोब्यूटामाइन. whereas in a case of chronic or compensated congestive heart failure में हमें क्या क्या करना होगा? We need to decrease the preload and afterload, so we'll give this dilators like nitrates and hydralazines. फिर उसके बाद then we need to decrease the fluid, then we'll give what? We'll give the diuretics. फिर उसके बाद क्या करना? We need to decrease this left ventricular hypertrophy or remodeling. तो तभी हम क्या करेंगे? We'll give this carvedilol, metoprolol, and bisoprolol. फिर उसके बाद उसके साथ साथ we'll give this drugs which also decreases this remodeling and decreases the mortality, which includes sacubitril, beta blockers, ivabradine, and spironolactone. Ivabradine and spironolactone. Yeah, nebivolol. These are these drugs which we use as a selective beta blockers for this heart. Next about this classification of antiarrhythmic drugs. So you know this mnemonic, I guess, right? So beautiful Priyanka Chopra. So it is what it is. This so beautiful Priyanka Chopra. So it is what it is. This so beautiful Priyanka Chopra. So if you see this thing, then the class 1, they are this sodium channel blockers. Okay, and this class 1, they are classified into 3 more classes. It is class 1A, 1B, and 1C. How they are classified? It is based on this potassium channel action. So if the potassium channel is getting blocked, it will be seen in a case of 1A. Okay, it is seen in a case of 1A. And because of this potassium channel blocking, it will lead to this QT prolongation, which is known as what? Which is known as Torsades de Pointis. Which is known as Torsades de Pointis. And the drugs which include or which comes under this classification of 1A, it include this procainamide and quinidine. It includes procainamide and quinidine. Next one, it is the 1B. 1B, it opens the potassium channel. It includes lidocaine and phenytoin. It includes this lidocaine and phenytoin. Yeah, good guys. In the case of Torsades de Pointis, we'll use, to treat this, we'll use magnesium sulfate. We'll use this magnesium sulfate. Okay? फिर उसके बाद 1C, it is the flecainide. Flecainide will use in the case of Wolff-Parkinson syndrome. Then about beautiful, we'll use this beta blockers, which are classified as class 2, whereas 3, but is P for Priyanka, it is the potassium channel blocker. As I told you, there also will be these Torsades where we can use this MGSFR, and the main potassium channel blocker, it is what? It is this amiodarone. And if there is a long-term use of this amiodarone, it leads to this blue man syndrome. Yeah. Then about this Chopra, it is this calcium channel blockers, which is especially this L type of calcium channel blockers. This includes verapamil, which is used as a prophylactic for this PSVT. Prophylactic for this PSVT. So, the Priyanka Chopra is very beautiful, or so beautiful Priyanka Chopra, it will be having additional guys who will be roaming as a security. So, we have this class 5 drugs. This includes this digoxin, atropine, and adenosine. Digoxin is used for this atrial fibrillation in a case of patients with congestive heart failure, and along with this atropine, it is used for this bradycardia and AV block, whereas adenosine, it is used for this treatment or this acute management of this PSVT. Whereas for this prophylaxis of this PSVT, which drug will you use, guys? Next, about the statins. We know the statin drugs. Yesterday also we saw in biochemistry this HMG-CoA reductase inhibitors. What are they? They are the statins. So HMG-CoA synthase, it helps in the formation or the synthesis of ketone bodies, whereas HMG-CoA reductase, it helps in the formation of cholesterol synthesis, and if you incubate this process, then there will be decreased level of this cholesterol. So it is a statin. So statins will incubate this HMG-CoA reductase inhibitors. Next, the examples of the statins will be having the statins in their name. This include lovastatin, rosuvastatin, pravastatin, and simvastatin. And the mechanism, as I told you, it will incubate HMG-CoA reductase incubator. Yeah, the rosuvastatin, it is the longest acting, and their main purpose is to decrease this bad cholesterol, which is this decreasing the LDL. Then we have one more drug which is known as fibrates, and fibrates which will mainly use for the decreasing the triglyceride levels, to decrease the triglyceride levels. Okay, and fibrates include this fenofibrate and clofibrate. And along with this, it will decrease the triglyceride levels, and the mechanism of action is PPAR alpha incubation. We know this PPAR gamma incubation will be seen in a case of telmisartan, whereas here it is PPAR alpha will be seen in a case of fibrates. Then if you see this drug, which is this niacin increases this good cholesterol, which is this HDL. And we have few new more drugs. For example, bile acid sequestrants. We know this bile acid, it helps in the absorption of these fat particles. If we give these drugs against them, then it will decrease the absorption of cholesterol. This includes cholestyramine, cholestyramine, and cholestyvalum. Okay, this includes this cholestyramine, cholestyramine, and cholestyvalum. Okay, just remember, it is this cholestyramine, cholestyramine, and cholestyvalum. Next, about this next drug, which is this ezetimibe. Ezetimibe, what will happen is that with the help of bile it will absorb, but without it also it can get absorbed. But this ezetimibe, it will prevent this intestinal cholesterol absorption. Okay, intestinal cholesterol absorption it will prevent. So if there is no intestinal absorption, then obviously the level of the LDL will be decreased. So there will be a decrease in the LDL. Okay, फिर उसके बाद आते हैं PCSK blockers. PCSK blockers, their recent advantage, they are this monoclonal antibodies like evolocumab and alirocumab. फिर उसके बाद this PCSK9 inhibitors, what they will do, they will increase the LDL receptors. क्यों? Because what they will do, these are the antibodies and they will go and bind to the LDL. So if they go and bind, means there will be decrease in LDL. So the body will think there is no one is binding or there is no place to bind, so it will produce more of the receptors. So they will increase the LDL receptors to bind. Okay, then we'll move into these drugs which we use during this peptic ulcer disease. So this include the drugs which reduce the acid secretions, or famous proton pump inhibitors like omeprazole, pantoprazole. Then H2 blockers like ranitidine, and M1 blockers like pyranzepine and telanzepine. Then drugs to neutralize the acids like antacids like sodium bicarbonate, aluminum, and magnesium bicarbonate. Sodium, aluminum, and magnesium bicarbonate. Next one, this can occur due to the presence of infection like H. pylori. And H. pylori, to treat, will use this metronidazole, amoxicillin, and clarithromycin. And about the next group of drugs, they are known as ulcer coating drugs. And this ulcer coating drugs, which include this, what? This includes this sucralfate bismuth. Means they will just coat the ulcer and they will prevent from the injury from the acids. So it is this sucralfate and bismuth. And as I told you, this omeprazole and lansoprazole, they are actually what? they are this PPI. Yeah, we can use this triple therapy, which includes this antibiotics like amoxicillin along with this PPI like omeprazole or pantoprazole, then the sucralfate or bismuth. Fine. And omeprazole, it is a PPI and it is having a few side effects, like if there is, it will decrease the absorption of calcium, so it will cause osteoporosis. At the same time, it will decrease the production of intrinsic factor, so it will decrease the vitamin B12 level and it increases the levels of infections. Okay, the three side effects. One is osteoporosis, decrease in vitamin B12 and increase in infections part. Okay, and drugs affecting the motility. Which motility? If you see about the esophagus, there are few conditions which occurs due to the relaxation of the sphincter. For example, our GERD, gastroesophageal reflux disease, which causing this Barrett's esophagus. So this GERD occurs because of this less tension or this relaxation of the sphincter. So if we give some drugs which causes this tightly adherence, like this is the relaxation. If we cause, or if we give some drug which causes this tightly adherence, then we can prevent this GERD. So these drugs include the D2 blockers, IST receptor antagonists. This much pharma isn't enough for exam because it is difficult to remember drugs. Next, if you see this receptor, it is this D2 blockers, 5-HT4 antagonist, 5-HT4 agonist and motilin receptor agonist. This D2 blockers include metoclopramide and domperidone. Okay, metoclopramide and domperidone. If you see this metoclopramide, this can cross the blood-brain barrier and it can cause dystonia. Remember, which of the following antiemetic will cause dystonia? It is what? It is the metoclopramide. And domperidone, it is used in the vomiting in the case of levodopa induced vomiting. We know this levodopa, it is used in a case of Parkinsonism. So in such cases, we'll use this. Fine. And next, it is 5-HT4 agonist like cisapride, mosapride and renazapride. These are used in the case of GERD to prevent this motility. Okay. Next, in motilin receptor agonist, like for example erythromycin. If you take up this erythromycin, it will increase the motility. So this increases the motility of these drugs. And about this vomiting drugs, usually we know this one vomiting drug which is ondansetron, which is this 5-HT3 receptors, like which is this serotonin blockers, which is this ondansetron, and it is used in a case of yearly treatment for this chemotherapy induced vomiting. Okay, there will be this yearly treatment of this chemotherapy induced vomiting. And whereas for delayed, we need to use the substance P agonist like aprepitant. Okay, substance P agonist like aprepitant. Fine. So there will be, in a case of chemotherapy, there will be side effects. One of the most common side effects, it is what? It is the vomiting. So if this vomiting occurs within 24 hours, it is called, it is the yearly, so it is due to the ondansetron. If it is occurs after 24 hours, we'll call them as delayed vomiting. In such cases, we'll use aprepitant. Okay, fine. Then if you see, there are the drugs which we use for this constipation. Either will make the stool to be bulk. For example, the fibers will give them like fibers, bran, methylcellulose. These are these drugs which will improvise their fiber content of the stool. Next, on the osmotic agents, how we saw this mannitol, right? It will pull the water. It will pull the water so that the stool won't be hard. It will be softer in nature. This includes our lactulose. Then about this surfactant, it will soften the stool. It will soften the stool like docosahexaene sodium, calcium, and mineral oil and liquid paraffin. All of this, it will soften the things. Whereas we use some more thing which are known as stimulants, which include biscodyl, senna, and cascara. And one of this thing which causes this side effect, which is known as what? Melanosis coli. Can anyone tell me which of the following stimulant constipations drug which causes this melanosis coli? It is what? It is the senna. So if there is any over usage of the senna, then what will happen? This will lead to this type of side effect which causes this blackish pigmentation over the colon, which is known as what? Which is known as melanosis coli. And next, we'll see what are the drugs which we use in a case of osteoporosis. You know, the osteoporosis, there are multiple kind of drugs which we use. But whatever the case of osteoporosis might be, the drug of choice is what? The drug of choice is bisphosphonate, like alendronate. And we know this bisphosphonates are this drugs, they will cause what? They will cause this maximum esophagitis. So what we'll tell, once you take this drug, we'll tell the patient to sit straight for 30 minutes, then go and lay down. Okay, if we use this type of bisphosphonates, like injectable type of bisphosphonates for a longer time, it will cause this type of mandibular degeneration or mandibular necrosis. Okay, causes this necrosis over this mandibular region. Okay, then as I told you, it is the drug of choice for osteoporosis, and it is a drug of choice for hypercalcemia due to malignancies, and it is also drug of choice for this Paget's disease. Okay, then we have few more drugs which are used in a case of osteoporosis, but they serve as a different purposes. For example, if you see about this teriparatide, what will do? There is two phenomena. There is this osteoblast which form this bone. There is osteoclast which reabsorb the bones. This teriparatide, it will stimulate this osteoblast and it will bring the calcium and it will make the bone stronger. Okay, that is the teriparatide work. Whereas strontium ranelate, if you see, it will be acting in both things. It will increase the bone formation and it will decrease the bone resorption by acting into the osteoclast. So they will ask you, which of the following drug will act on this both mechanisms? Yeah guys, what will be answer? Your answer will be strontium ranelate. Your answer will be strontium ranelate. And next drug, which is this denosumab. If you see, as I told you, this osteoclast will be having a ligand which is known as what? Which is known as this rank ligand. So this denosumab, it is the antibody against this rank ligand. It is the antibody against this rank ligand. Next, there is one more antibodies or one more receptor which is known as sclerostin. So this antibody against this sclerostin, it is what? It is the remosuzumab. So denosumab, it is the antibody against the rank ligand, whereas remosuzumab, it is the antibody against the sclerostin. It is the antibody against the sclerostin. Next one, it is the cinacalcet. Cinacalcet, it is now for the stimulation of this SR receptors. They are actually what? Calcium sensing receptors. So they will stimulate this calcium sensing receptors. Fine. These are the drugs which you use for osteoporosis. So in this, you need to know first thing, you just remember all of these osteoporosis components, the drug will use, it is the bisphosphonates. Strontium ranelate, it will be used for both. It will be having this both mechanism, which is the bone formation and bone resorption. And teriparatide, it will stimulate the osteoblast. Whereas for rank ligand against the antibody, it is the denosumab. Whereas this sclerostin antibody, it is what? It is the remosuzumab. Fine. And next we'll move on to this antihistaminic drugs. Fine. Then about this antihistaminic drugs. If you see about this antihistaminic drugs, there are different generations. Mostly they will rely into this, how will you differentiate, or what is the reason which we use first generation drugs, or what is the reason which we use this second generation drugs. We know this first generation drugs, they have the side effect of sedation because they cross the blood-brain barrier, and as a side effect, what they will do, they have the side effects of antiemetic. But in few conditions, we use this antiemetic side effect as a effect. So, for example, in the case of doxylamine, we'll use in the case of morning sickness. So, for this drug of choice for morning sickness, it is doxylamine, whereas drug of choice for mountain sickness. What is the drug of choice for mountain sickness, guys? Mountain sickness, it is what? Acetazolamide. So, it is what? It is the acetazolamide. Okay, remember. Next, there is the drug which is known as promethazine, and this promethazine, it is also used for this prevention of this motion sickness. Okay, promethazine also. Fine. We'll use this common drug which is the diphenhydramine for this cough. For this cough, it is what? It is this Benadryl, in the form of Benadryl, which is the diphenhydramine. Fine. And the second generation, they won't cross the blood-brain barrier, so they won't produce sedation. Okay, it's include the levocetirizine. लेकिन हमें लीवोसिट्रसिन खाने के बाद भी नींद आता है और फार्मा पढ़ने भी वक्त भी नींद आता है. So whenever you read pharma, biochemistry, which is very hard subjects, then you will feel sleepy, and if you take levocetirizine, then also you will feel sleepy. But actually levocetirizine, it will not cause sedation. Okay, and we'll use this one more drug which is known as, which there is, I guess I told correct. Yeah, we'll use this one more drug which is known as hexofenaclin, which has a side effect of QT prolongation. And this second generation, they also used in a case of allergies or similar common cold. And there are few drugs which can be used in a case of Parkinson's. For example, our promethazine, they can be used in a case of drug-induced Parkinson's diseases. Fine. And mainly, but we'll use in a case of like benzhexol bipyridamine. Okay. Next, about this migraine, there will be one question because it is interlinked with pharma and medicine. It is interlinked with pharma and medicine. So just remember. So this migraine drugs, initially, if it is mild migraine, she is complaining, sir, there is a headache, but I am able to bear it off. Then you try using the NSAIDs. But later on, if there is any acute episodes or very severe episodes, then you should use this proper drugs. What are the proper drugs you will use? The proper drugs you will use include the 5-HT1B1 receptor antagonist. Okay, wow, that's good, Dr. Mohammed Shanwaz Khan. That's good. That's good. Yeah. That is the split Shanwaz. Fine. If you see this drug, which is this 5-HT1B1 drugs, these are what? They are this triptans, like sumatriptan. Okay, these are the sumatriptan drugs and razitriptan. These are this drug which is used in a case of severe migraine and in a case of acute episode of migraine. So in a case of mild, we'll start with NSAIDs, whereas in a case of severe and acute episodes, we'll use this triptans, which is what? Which is this 5-HT1B1D receptor agonist. It is not antagonist, it is the agonist, because there will be, it will cause what? It will cause vasoconstriction or decreased blood supply to the cranial vessels, so that it will be relieved from this headache. Fine. And next, about this prophylaxis of this migraine, we can use this propranolol. We'll use this propranolol, and we can use this intranasal butorphanol. We can use this one more drug, which is the intranasal butorphanol. Fine. And new drugs which are in the market, they are known as lasmiditan, which is 5-HT1F receptor, and it will decrease this CGRP release. So if you can just remember this one drug, which is this lasmiditan. Then monoclonal antibiotics which is used here, it is the erinumab. Fine. And there is a CGRP agonist, which is the olzigapant. Okay, this lasmiditan, erinumab, and olzigapant. Okay, these are the drugs. Yeah, last time this was the question, like what is the drug which will use for the prevention of the migraine? So agli baar they will ask some more questions, so make sure you are reading them perfectly. Take it perfectly. Okay, hence what are the drugs used in the epilepsy? It is a 3 subjects integration. It is a pharma, pedia, and medicine. So in a case of generalized tonic-clonic seizures, if it is active seizure, first we will give the lorazepam. Okay, and we will position them. Whereas in a case of GTCS, first we will use this drug, which is this lamotrigine. Lamotrigine you will use. If there is no lamotrigine, you can try for valproate or levetiracetam. Whereas this drug of choice, it is what? It is the lamotrigine. लेकिन lamotrigine का भी कुछ side effects है. If used in a case of for a prolonged time, it can, or elderly, it can lead to this Stevens-Johnson syndrome and toxic epidermonecrolysis. फिर उसके बाद है valproate. Valproate causes liver damage and pancreas damage and PCOD. ठीक है, valproate में याद रखना, it causes liver damage and PCOD. Liver damage, PCOD by this valproate. And yeah, and this lamotrigine, which will be used for a case of GTCs, and it is the drug of choice. Badhiya Nida Anjali. Good. Then about this partial and focal seizures. About this partial and focal seizures, here you need to use this drug, which is this carbamazepine. Remember, it is a carbamazepine which is used in a case of trigeminal neuralgia as well, and also in a case of partial seizures. Okay, and in a case of absent seizures, and it is mostly the pediatric patients. They will tell like the child is presenting with this like a vacant look. Okay, he will become absent for a few seconds. So it is known as what? It is known as absent seizures. And for the child who is less than 2 to 3 years, we'll use this ethosuximide, or if it is child is more than 3 years, we'll use valproate. Okay, yeah, that is the criteria, guys. Yeah, less than 30, or we will call, means like if there is less, we'll call them as Stevens-Johnson syndrome. If it is more, we'll call them as toxic epidermonecrolysis. If it is, we'll call them as spectrum type of disorders. Okay. Then about these 2 drugs or 2 phenomena, just infantile spasm, then we'll use ACTH. If there is just infantile spasm, we'll use ACTH. Whereas if there is a presence of this infantile spasm along with this tuberous sclerosis, remember it is the TB. If there is tuberous sclerosis, हम यहाँ क्या देंगे? We'll use this vigabatran. Yeah, good guys, good Ansh and good Shanvas. We'll use what? We'll use vigabatran. बढ़िया. Then in a case of eclampsia, तब हम देंगे magnesium sulfate. Whereas in a case of hypertensive emergency in pregnancy, में हम क्या देंगे? We'll give IV labetalol. Hypertensive emergency in pregnancy, we'll give IV labetalol. Whereas in a case of eclampsia, we'll give magnesium sulfate. And in the case of status epilepticus, as I told you, we'll take up this lorazepam. हम क्या देंगे? Lorazepam देंगे. ठीक है, कोई भी benzodiazepines. Okay. And in the case of febrile seizures, we'll keep this rectal diazepam, because the child is having the seizures. So we cannot access to his mouth. So we'll put the rectal suppositories. So we'll give this a rectal diazepam, okay? Or else sometimes we can give intranasal midazolam as well. Intranasal midazolam as well. And about this final drug, which is the phenytoin, which previously we used for this both GTCS and partial seizures, because of the side effects, we'll use them at the last resort. So this phenytoin will cause the side effect of gum hypertrophy, hirsutism, and deficiency of this folate, vitamin K, and vitamin D. So it causes 3 deficiencies: folate deficiency, vitamin D deficiency, and vitamin K deficiency. Whereas we know this one, valproate, it will cause what? It will hepatic damage and PCOD. Whereas this phenytoin will cause gum hypertrophy, folate deficiency, vitamin K deficiency, and vitamin D deficiency as well. And this phenytoin, it is teratogenic. And in questions they will give you, there is a female who is willing to be pregnant. Now she is taking phenytoin, okay, or valproate. So what you will do? Yeah, guys, what you will do? Will you change or keep like this? You will change. You will change into levetiracetam, okay, levetiracetam or either lamotrigine. Mostly in the case of lamotrigine. Whereas if the female who is already pregnant, okay, here the most preferred one, it is the levetiracetam, okay. The female who is already pregnant, let me write in good handwriting, okay. Female who is already pregnant, now, and she is taking valproate or phenytoin, and it's her 13th week, okay. If she's already pregnant, then don't change them. If she's taking phenytoin, tell her to take the same. Don't change it. If you want, additionally, you give this folic acid supplementation, okay, okay, which is a therapeutic dose. Folic acid supplementation you give them. Yeah, guys, good, absolutely awesome. You are in correct pace. You are in perfect lineup, perfect. Okay. Well, then we'll see about this gout. Okay, gout. If there is any initial stages, if there is any simple gout, or if there is any simple gout or mild gout, what we'll do? We'll start with this NSAIDs like indomethacin. Or if there is an acute gout, there will be this uric acid. But here the uric acid is not the problem. It is the cells which is causing this inflammation. Because of this uric acid is the problem. Okay, so in such cases we'll use anti-inflammatory drugs. We'll start with non-inflammatory non-steroidal anti-inflammatory drugs like indomethacin. Followed by this we can start steroids. Whereas we can give one more drug which is known as colchicine. And this colchicine, it will inhibit this tubulin which prevents this neutrophil migration. Yeah, we studied one thing, that interleukin 8, it causes neutrophil chemotaxis. And if this neutrophil need to move, then there should be this tubulin component should be present. Okay, this tubulin component should be present. So in such cases, if you don't want them to move, we'll break this tubulin, and once you break this tubulin or you will incubate this tubulin, it will cause this neutrophil chemotaxis to be incubated. So there will be no neutrophil going to there, and if there is no neutrophil goes there, there will be no inflammation at the site, then there will be no pain. So this is the management of acute gout. Whereas in a case of chronic gout, the main problem it is the increased uric acid. Either what you can do, either you make them to excrete out of the body, or you make them to produce into alternate component, or you produce it decrease, or you decrease the production. So what we can do is that we can incubate this xanthine oxidase which produces this uric acid. Okay, the drug which you use, it is the allopurinol. So remember, allopurinol, it is used for chronic gout and it is a drug of choice. And we can use other drugs like febuxostat, which is also an xanthine oxidase inhibitors. We can use one more drug which is probenecid, and this probenecid, what is the help it will do is that it will increase the excretion of this uric acid. And then we can use one more drug which is known as recombinant uricase, like rasbicuricase and pegloticase, and both of this thing will be used especially in a case of tumor lysis syndrome. We know in a case of tumor, we give what? We give chemotherapy. Once we give chemotherapy, the cells will be broken. Once the cells are broken, it will get into digest. Then there will be the proteins and there will be the purines, and all of them it will convert into what? It will convert into the uric acid. So what we'll do, Allopurinol, it is also used in a case of Lesch-Nyhan syndrome. Yeah, great guys. You see, this uric acid will be produced. So what we need to do is that we need to make this uric acid to be excreted out. So in such scenarios, we'll use this drug. They are known as what? Rasburicase and pegloticase, used in a case of tumor lysis syndrome. Okay? Then about this antimicrobials. Antimicrobials में तुम्हें बस इतना याद रखना, what is the mechanism of action of antimicrobials. अगर तुम्हें देखना cell wall synthesis incubators, remember by this mnemonic, firmly bind to bacterial cell wall. Okay, so here you need to know about this beta-lactam. So bind to refers to this beta-lactam. Firmly for phosphomycin, bind to for beta-lactam, and beta-lactam they will incubate this transpeptidases. So if it incubates this transpeptidase, it won't form the cell membrane, and if there is a disruption of the cell membrane, the bacteria will die. And followed by this, B for bacitracin, cell for cycloserine, and V for vancomycin. And vancomycin, it will incubate this transglycosylase, which helps in this elongation of this cell membranes. So vancomycin, it incubates this transglycolase. बस इतना याद रखना. Okay, fine. Then about this protein synthesis incubators, there are two classifications. There are this 30S incubators and there are this 50S incubators. This 30S incubators, remember it as by at 30 and cell at 50. ठीक है ना? तुमने 30 पे कर दा और 50 पे भेज दिया. तो A for aminoglycosides and T for tetracyclines. And 50S, remember it is for cell. So it is the streptogramins, which previously we used to use, and the erythromycin, which comes under this macrolides, and then linezolide and lincosamide. Linezolide, lincosamides, yeah, good Dr. Shanavas, good Dr. Anjali, and then chloramphenicol and clindamycin. Chloramphenicol and clindamycin, these are these two additional drugs. So cell, it is what? It is the streptogramins, erythromycin like macrolides, and linezolide and lincosamide. Linezolide and lincosamides. These are the protein synthesis incubators. Then about this like metabolisms, like for example sulfonamides, they are this metabolism incubators which acts on this folic acid synthesis. So this includes the sulfonamides, and there will be this combination of these sulfonamides. They are known as what? Cotrimoxazole. And this cotrimoxazole, it is used in a case of Pneumocystis jirovecii. It is used in a case of Pneumocystis jirovecii, and it causes pneumonia, which is known as PCP pneumonia in HIV positive patients. And if you see this PCP pneumonia, if you see this PCP pneumonia on staining, like staining with Gomori methylamine silver stain, it will produce a typical appearance of which appearance? It will produce the appearance of crushed. Remember, it is the crushed ping pong ball appearance. It produces this crushed ping pong ball appearance. It will produce this, as there is a silver stain, silver will showing this block. So see, it is the normal ball, it is the crushed ball. Okay, it is the crushed kind of ball. Okay, it is a crushed ball. Okay, fine. Next about this trimethoprim and pyrimethamine. Then about this DNA gyrase. This DNA gyrase inhibitors, this include this fluoroquinolones. And we know this fluoroquinolones, they cannot be given during pregnancy because they interfere with this. Which function? They interfere with this formation of this tendons. Okay, tendons in the teeth. And drugs acting on the cell membranes include daptomycin, polymyxin B, and polymyxin E. So membrane, it is the MD. Membrane, it is the daptomycin. It is the daptomycin. फिर उसके बाद आते हैं antineoplastic drugs and its side effects. हमने पढ़ा है कि one of this most common side effect of this antineoplastic drugs क्या? That is what? It is the vomiting. So in a case of yearly chemotherapy induced vomiting, हम क्या करेंगे? हम क्या देंगे? In a case of yearly chemotherapy induced vomiting, we'll give ondansetron. अगर if there is a case of delayed chemotherapy induced vomiting, तब हम क्या देंगे? We will give aperipitant. Okay, we'll give what? We'll give aperipitant. बस इतना याद रखना. Then about this alkylating agents. Okay, about this antineoplastic drugs, we'll just see very superficially. If you see these alkylating agents like cyclophosphamide, it will cause a side effect which is known as hemorrhagic cystitis. In bladder, it will cause hemorrhages. It is known as hemorrhagic cystitis, and to prevent this, we'll use this drug which is known as Mesna. And there is one more thing which is known as Melphan. It is used in a case of multiple myeloma, which is also in alkylating agents. And busulfan, it will cause pulmonary fibrosis. It will cause what? It will cause this pulmonary fibrosis. Then there is this platinum components, and this platinum components, it like cisplatin, it will be causing this nephrotoxic and ototoxic. Next one, anti-tumor antibiotics like doxorubicin, daunorubicin. हमें पता है रूबी दिल ले जाती है. Okay, so while this ruby drugs, it will cause damage to this heart and because what? Restrictive cardiomyopathy. So to prevent this, we'll use this antidote which is known as what? Dexrazone. Okay, it is the, yeah, not though. So it is what? It is the dexrazone, remember. And next one is the bleomycin. Bleomycin and busulfan, both of them, they causes what? They causes this pulmonary fibrosis. And remember one more thing, this bleomycin will cause this kind of flagellated pigmentations over the trunk. It will cause this type of flagellated pigmentation. Then one this vincristine and vinblastine. Remember this vinblasting. Okay, vinblasting will suppress the marrow. So remember, vinblasting, it will blast the marrow. Likewise, it suppress it. Fine. 5-fluorouracil. This is asked in the recent FMG examination. It will cause hand and foot syndrome. And cytarabine, it will cause this cerebellar side effect. It will cause this cerebellar side effect. Okay, I have given these two things. One is this antidotes and the drug of choice, whatever mostly I discussed. There are few extra will be here. So you just go through this drug of choice. Whereas antidote I will tell you. Okay, for ergot alkaloids, it is the nitroprusides. For example, in a case of migraine, previously we used to use this ergot alkaloids. So and it will cause severe vasoconstriction. So for this we'll use this nitroprusside. And beta blockers will use glucagon. Beta blockers will use glucagon. And OPC and carbamates, I told you, it is the atropine. And OPC extra will use what? Will use what? Along with this OPC, atropine will use this pralidoxin. Okay. And benzodiazepines or all the Z drugs will use flumazenil. Okay. Like what is the Mazeco nil karne wale drug. Then cyanide will use hydroxycobalamin. Then amyl nitrate. Yeah, good. Dr. Shanavas, Dr. Anjali, good Punit. Yeah, good. Okay, amyl nitrate and sodium thiosulfate will be used as an antidote for cyanide. And can anyone tell me cyanide inhibits which of the following component of this electron transport chain? That is the fourth one. It is the fourth one. Okay, that is the fourth one. Yeah. Then alcohol will use this drug which is the fomepizole. Iron will use this desferroxamine. Then acetamide, paracetamol, we know paracetamol toxicity, will use this N-acetylcysteine. And aspirin, what will do means because of this, it is an acidic drug, then we need to do forced alkaline diuresis. If there is any alkaline drug, then we'll use that forced acidic diuresis. But mostly for acidic drugs only, we'll do this forced alkaline diuresis. Then about, I told you, isoniazid, there will be toxicity, will give pyrazine. And opioids will use this naloxone, and one more drug which is the maintenance drug which is this naltrexone. Fine. And opioids will be naloxone. And scorpion sting, what will use? Yeah, good Dr. Punit. And scorpion sting will use prazosin. And for atropine, I told it is the physostigmine. Fine. And about this physostigmine, belladonna and datura poisoning will use atropine. So it is the interchange of this both these two. Fine. And this XA inhibitors will have this XA, which is the andexanate. Okay, it is the andexanate alpha. Next about this dabigatran. It is dabigatran. We'll use this idarizumab. Dabigatran, it is the idarizumab. And we know it is the one of the oral direct acting thrombin inhibitors. Then for heparin, we already discussed, it is the protamine sulfate. And cyclophosphamide, which is causing this hemorrhagic cystitis, will use this mesna. And cisplatin will use amifostine. Okay, anthracyclines like ruby, जैसे दिल ले जाती है, like doxorubicin and daunorubicin will use dexrazone. Then for methotrexate, we'll give alternate folic acid. Alternate folic acid, also known as leucovorin. So remember about these antidotes, and just most of this drug of choice I have discussed. Just go through this drug of choice once. Okay? So whichever I have not discussed, I will tell you. Okay? So antithyroid drugs in pregnancy, it is the propylthiouracil. Okay? Then brucellosis, you should use doxycycline and rifampicin, and rest we told mostly. Cytomegalovirus, you should use ganciclovir. Fine. And diabetes insipidus, as I told you, if it is mostly, if it is central, then we'll use desmopressin. If it is nephrogenic, then we'll use thiazide-diuretics. If it is only lithium induced, then we'll use this amiloride. In type 1 diabetes, we'll use insulin. Type 2 will use what? Oral hypoglycemic agents. Okay, and like metformin. And ketoacidosis will use insulin along with IV fluids. Whereas pregnancy will use mostly of insulin. Okay. Drug-induced Parkinson's, we told it is what? It is the benzoxazole. Good guys. Then typhoid will use this ceftriaxone. And we told like this altiplase, if there is an overdose, we'll use this EACA or tranexamic acid. Fine. For the cystodes and trematodes, we'll use praziquantel. For nematodes, we'll use albendazole. For giardiasis, amoebiasis, and trichomoniasis, and also for bacterial vaginosis, we'll use metronidazole. Then about herpes simplex, we'll use valacyclovir, and in hypertension pregnancy, we'll use 3 drugs. One is what? One is this labetalol, then alpha methyl dopa previously we used to use. Then we'll use for emergency, we'll use IV labetalol. Okay, and in emergency, we'll use nicardipine. Yeah, fine. Yeah, that is the mnemonic for this metronidazole. Yeah, good guys. Fine. For osteoporosis or any osteoporosis, it is the bisphosphonates. Okay, and talk with oliguramia, it is what? It is the dopamine. Okay, and steroid induced osteoporosis, any osteoporosis, it is bisphosphonates. Okay, and for surgical prophylaxis, we use cefazolin. And hypothyroidism, our only one drug, which is what? Which is this levothyroxine. Whereas if it is a case of hyperthyroidism, तभी हमें सोचना है, because usually we'll use carbimazole or methimazole. Whereas in a case of pregnancy में it can lead to this aplasia cutis. So in such conditions, for first trimester of pregnancy हम क्या use करेंगे? Yeah, that is good guys. It is first trimester में हम क्या करेंगे? Propyl thiouracil. Yeah, good Anjali, good Shanavas. It is the propyl thiouracil. फिर इसके बाद second and third trimester में हम use करेंगे methimazole और carbimazole. और हमें पता है कि syphilis will use benzathine, penicillin, and termination of PSVT will use adenosine, and for prophylaxis we are using verapamil. For toxoplasmosis we'll use pyramycin, and PDA, yesterday we discussed PDA is a which pharyngeal arch artery? Yeah guys, it is which pharyngeal artery? It is a 4th, 5th, 3rd, 2nd and 6th pattern ductus arteriosus. Or ductus arteriosus is which pharyngeal arch artery guys? Yeah, treatment of PDA is indomethacin or ibuprofen. Yeah. Yeah, for keep it open, like in the case of any cyanotic disease, then we'll use prostaglandins or lax like alprazolam. Good, fine. Then about this trigeminal neuralgia, today only we discussed, it is the carbamazepine. And hypertriglyceridemia, we used to use fibrates, and this to decrease the LDL, we were using this statins. Fine. And about this infantile spasm, we used ACTH, and Kala-Azar will use this liposomal amphotericin B, and malignant hyperthermia will study in anesthesia, will use dantrolene sodium. And for mydriasis, in children, today only I told atropine will use, whereas in adults will use topiramate. Okay. And for oral hypoglycemic agents in obese patients, it is the metformin, and also will use in a case of PCOD. And influenza E will use oseltamivir. And for prophylaxis of this malaria, okay, usually there are 2 things, like prophylaxis of the malaria and yeah, Kala-Azar VQ, we use RK39 test. Yeah, that's absolutely awesome. Yeah, good guys. So in case of prophylaxis of this malaria and treatment of the malaria, prophylaxis, there are 2 prophylaxis. One is the short-term prophylaxis, another one it is the long-term prophylaxis. So remember, short-term will use doxycycline, long-term will use mefloquine. And for treatment, there are 2 areas. Northeastern state will use artemether along with lumefantrine. Yeah, mefloquine. Yeah. Whereas in a case of rest of India, it is artesunate plus sulfadoxine or pyrimethamine. Okay. Remember, it is northeast. It is the artemether plus ARL. Okay. It is the northeastern state. Remember. Yeah. Doxycycline daily for less than 6. Yeah, that's absolutely awesome. For plague, we'll use doxycycline. Then for pneumocystis pneumonia, as I told you today, it is the cotrimoxazole. And rheumatic fever, we discussed in pathology, the drug of choice for prophylaxis, it is the benzathine penicillin. We also use for syphilis. Then for whooping cough, we'll use macrolides like erythromycin. Then focal seizures, it is the carbamazepine. And performance anxiety, and as a migraine prophylaxis, we'll use what? We'll use propranolol. Yeah, that's it guys. That is about the main point. Just we'll look into this few extra dates, then we'll wind up for the day. Fine. If you see about this receptors, there are few receptors. This ionotropic receptors, they uses the ions. So once they use these ions, they are the much fastest in nature. This includes GABA A, NMDA, NN type of receptors, and NM and 5-HT receptors. All of them, they are the ionic receptors and they are most fastest receptors. Then you use this tyrosine kinase receptors. You remember this pig, prolactin, insulin and growth hormone. They are the pig hormones. They act by this receptor which is known as tyrosine kinase receptor. Fine. Then there are this few intracellular receptors. In intracellular there will be two types. There might be intracytoplasmic or intranuclear. Intracytoplasmic one, it will be for this vitamin A, glucocorticoids and mineralocorticoids. It is the DMG, vitamin D, mineralocorticoids and glucocorticoids. Whereas nuclear, it is this vitamin A, thyroid hormones and sex hormones. Fine. And other receptors, they are this GPCR type of receptors. Fine. That's it. You need to know about this receptor points and about this benign prostatic hyperplasia. As I told you, this benign prostatic hyperplasia along with this hypertension will use zosine type of drugs like prazosin, terazosin. Okay. Then there are two components. For example, the patient will be complaining of two things. Either he will be complaining of acute things because of this prostate hyperplasia. So we can do two things. We can give some drugs which give an instant relief to him, or else we can give some drug which decreases this synthesis of this new cells again. Okay. So if you see this alpha 1A blockers, it will give this immediate relief by acting on the dynamic component. So that is what that is this tamsulosin. Whereas we know this happens because of this conversion into this 5-hydroxytestosterone. So what we'll do, we'll give this 5-alpha reductase drugs to incubate this conversion. So to incubate this conversion. So the drugs include this finasteride. The drugs which include it is the finasteride and it will act on the static component. So dynamic component, it is the tamsulosin which is an alpha 1 blockers, whereas 5-alpha reductase inhibitors will use finasteride which is a static components. Okay, bas itna yaad rakho. Yeah, good Dr. Naresh. Yeah, good Dr. Shan Muska. And during chemotherapy or some other aplastic crisis, we need to give some supplementation or we need to promote the growth of this new blood cells. For RBC, we need erythropoietin. So we have this poietin analog which is this dabropoietin, which is used in a case of chronic renal failure where there is decreased erythropoietin. Next one, WBC. For WBC, there will be this leukopenia after this chemotherapy sessions like bone marrow suppressions. In such cases, we have two things. If it is GCSF, we'll give filgrastim. If it is GMCSF, if it is include the monocyte also, it is sargramostin. Remember. And for platelets, we'll use oprivilkin, which is an interleukin 11 stimulant. Fine. Then about tuberculosis, we know this first line drugs, HR is a T. Okay. And we know isoniazid causes 6 deficiency. Patient took some medicine and had episode of orthostatic hypotension. What was the drug? Answer, yeah. They may be asked this question like, yeah, it is one of the means it is used in hypertension, but it can cause one more side effect. Side effect, it is what? It is this orthostatic hypotension. So it is the side effect of it. Yeah, good point, Dr. Puneet. Fine. This is the first line drugs. It is the HRST. Fine. It is this isoniazid which is causing this, pyridoxine which is causing this peripheral neuropathy, and rifampicin, it will cause red colored secretions like red colored urine. Okay, urine and what? Red colored urine and red colored tears even. Okay. Then ethambutol, it causes this red clean color blindness because of this optic neuritis. And we have few new drugs, like just remember this name. They are this bedaquiline, delamanid and protamanid. And now there is a TB patient who is presented with HIV. So what he will do first? Will he start HIV treatment first or TB treatment first? You should do the TB treatment first. And after 2 weeks, yeah, good. First TB treatment. After 2 weeks, what he will do? He will start this HIV treatment. Best. Yeah. One of the side effect of bedaquiline, it is what? It is the QT prolongation. Yeah. First it is the ATT followed by this HIV treatment. For HIV, what we'll do? We'll give this type of drugs in the name of regimen which is known as highly active antiretroviral therapy. And in this, we'll give this combination methods which includes 2 NRTIs plus 1 NNRT or integrase inhibitors. So usually we'll give this TLD, tenofovir, lamivudine and dolutegravir. This is the usually fixed combination we'll give, and the same we'll use for this post-exposure prophylaxis. Like imagine, means you and your friend cleared your from the examination. Now you joined an internship, and while collecting sample, unfortunately sometimes you pricked your finger or your friend pricked your finger. Then you should take this post exposure prophylaxis if the patient is HIV positive. Then in such cases you need to take this TLD. You need to start this TLD within 72 hours, and you need to take for 28 days or 4 weeks. Okay, yeah, that's it guys. That's it for this HIV one. And finally, as I told you about this malaria, for eastern states will use artemether along with this lumefantrine, whereas for rest of the states will use artesunate along with sulfadoxine and pyrimethamine. Okay, sulfadoxine and pyrimethamine. So these are these drugs and things you need to know from the pharmacology perspective about this most and most important topics. And if you know these things, it will change your game for sure.